Hi, my name is Stephanie Wallace. I'm a genetic counselor with the vEDS Collaborative out of the University of Washington and the Department of Surgery. And today I'm going to be giving a vEDS Collaborative study update on where we are and where we're going. For disclosures, I will disclose that I am an employee and shareholder of a diagnostic genetic testing laboratory. However, today I will not be discussing genetic testing at all. So on today's agenda, I'm going to go through an overview of the study. So what it is we're looking for, what we're collecting, the priorities that were outlined by our community stakeholders as information that they feel like they need as part of their care, the methods, including enrollment and how we've been gathering this information, a description of the vEDS Collaborative as it is today, and then the current projects that we're working on. So in 2019 and 2020, we reached out to our community through social media, as well as our community stakeholders reached out to other individuals within the vEDS community to find out exactly what was the information that they felt that they needed. So we sent out a survey and we gathered several pieces of information. And the things that were highlighted were more information about vEDS treatment, information about vEDS screening and surveillance. Pregnancy in vEDS was highlighted. Barriers to vEDS care, and then also exercise in vEDS. So this information was published in October 2020, as you can see, and has really driven how we have structured the research and the goals moving forward. So as some background, this group in particular is no stranger to the challenges within the vEDS community. It's difficult to get large numbers and also just to get the medical records and the imaging to really provide us with the solid information. And so within this community, because it's smaller, there is definitely a lack of that information. It's difficult to get genotype phenotype correlations because those numbers are so small. So we are still working on trying to use that genetic information to drive decision making. And then there's also significant ascertainment bias in the literature, as we know, because typically people with a more severe onset are caught sooner. And this is just common across genetics in general. So one of the things that the study is looking to answer and fill a gap for is creating a comprehensive natural history, as well as making sure that patients have an input into the research priorities that are driving those goals forward. So we enroll individuals in a couple different ways. Many folks come to us. Our community members are really wonderful about saying, hey, this exists, go enroll here. So we have a lot of great community engagement. So oftentimes participants will reach out and just contact the vEDS Collaborative, at which point once one of our research personnel will go through the study, go through the consent form, and send it off to them to sign. Once they've had a chance to review and consent and sign and send it back, we start our data collection. And so we do this as in partnership with that participant if they have their own records, and gather as many and abstract those medical records as possible. The other way that folks come to us is through our physician collaborators. So a physician will reach out to us and say, hey, I have this patient, and we'll put us in contact with the patient, at which point we can go through that enrollment process, and we can work with those physicians to gather their medical records and begin to abstract them as well. Now, I keep saying medical records, and that's because there's a few key components to the vEDS Collaborative. Number one, every person who is used in our data analysis and that is part of the vEDS Collaborative has to have a genetic testing report showing that COL3A1 mutation. So we do have genetic confirmation of every individual in this population. And the second is we're trying to avoid self-reported data as much as possible. We're looking for documented medical records to verify dates, ages, times, sizes, and the procedures that were performed when we're abstracting. We're abstracting over 1,500 variables currently, and it keeps growing as we add collaborators. And that's one of our goals right now, is to move through all of the individuals that we have to abstract all of those data points so that we can start pulling them for research. So as you can see, we enroll folks from all over the world, but particularly within the United States. And it's no surprise, Washington, Dr. Shalhoub, who's running this project, along with Dr. Byers, are located in Washington. So we have a little bit of a higher enrollment over there. But you can see we've been enrolling folks all across the country. And a lot of our great collaborators send folks over to us. And even across the world, Australia, Canada, Europe. So within the population, this is the breakdown right now. So about 63% female, 36, almost 37% male. We have, as an age of enrollment, you can see this sort of stratified ages here. The bulk of our participants are between 26 and 39, and going all the way up to 50. We are currently enrolling pediatric patients, and then we have some pediatric collaborators as well. But currently the median age of our study is 39, with an interquartile range of 26 to 50. When we're looking at mutation type, we broke it down by age, and you can see, not surprisingly, glycine substitution is the most common within this population. We also see some exon skips, and in sort of no surprise, haploinsufficiency is showing up a little bit later. We have over 143 unique variants within this population. And then when we break it down by arterial disease, you can see we're looking head through pelvis, similar to how we're doing a lot of the imaging. So breaking it down into carotid arteries, vertebral arteries, those visceral arteries, some mesenteric, subclavian, renal, as well as the aorta and the iliac. The aorta is further broken down within our data set because abdominal disease is significantly different than thoracic disease within this population. And as you can see, iliac was one of the largest groups within this population. So our cohort is not just our vEDS collaborative. We've been really fortunate through other studies and other collaborations to be able to add individuals and data to that. So on the right-hand side of the screen, you'll see this is a breakdown of all of the data that we have currently. So we've been fortunate to partner with Dr. Byers and his cohort to gather the medical information, abstract the records on those individuals, Genentech, as well as Adaptive. And then we've also been going through publications and case reports to abstract the data from that. Now, across all of these groups, we are using the mutation as well as demographics to look to see, do we have duplicates so that we can remove them and only count those individuals once. Our current project, so Dr. Shalhoub has built a little bit of an empire of individuals. We've had a lot of interest from different students, from residents, from medical students. So we're fortunate we have multiple projects going on. As we saw, iliac artery disease, really prevalent within this population. So we are abstracting a lot of data on iliac artery disease, surgical interventions, and best sort of care and practices of care for that population. We also have abdominal aortic disease in vEDS, and then mesenteric and renal artery disease in vEDS. And then on top of that, we're collaborating. As the name says, this is a collaborative effort. We need, trying to get as much data on individuals requires multiple teams from multiple locations. So we are always looking for partners, especially if you have a passion for a particular aspect. We are always looking for partners to collect and gather and put together data. So we are working on pediatrics in vEDS. We are partnering with pregnancy in vEDS, as it was mentioned, it's one of the priorities of the community, and then GI disease in vEDS. So as I mentioned, it's a collaborative effort. We are always looking for new partners. We are looking to always combine data sets to provide the best care to this community. So these are a lot of our collaborative network and folks that we have partnered with and will continue to partner with as these priorities change and adapt. And then last but not least, this is the research team that has been put together in the last couple of months. So you can see we have quite a few different individuals working on lots of different projects being led by Dr. Shalhoub and Peter Byers. So huge shout out to that team who's been hustling so hard to get a lot of that data abstracted. And most importantly, just a shout out to the community who have been the best partners with us. They are so impressive and so wonderful. And so they've just really led a lot of the project here. And so a huge thank you to them and the vEDS movement.